Welcome, and thank you all for coming to the Philadelphia College of Physicians Public Health Grand Rounds on obesity in Philadelphia. My name is Michael Halpern. I'm a faculty member in the Department of Health Services Administration and Policy at Temple University College of Public Health, and a member of the Executive Committee of the Public Health and Preventive Medicine section of the College of Physicians. Can I have the next slide, please? Pretty please, can I have the next slide? Thank you. The Philadelphia Public Health Grand Rounds are held 3 or 4 times a year by the College of Physicians. The purpose is to address important public health issues in the Philadelphia area. We include local speakers from multiple disciplines and perspectives, and we hope to generate new ideas and collaboratives and strengthen the local public health community. I'd like to thank the co-sponsors, which are the College of Physicians and the Philadelphia Department of Public Health, and particularly acknowledge the Thomas Skelton Harrison Foundation for their support of this event. Next slide, please. Following the grand rounds, there'll be a series of question and answers. We have a microphone in the middle aisle, so after the fourth speaker, we have 4 speakers tonight, please come up, ask questions. We hope for an interactive and stimulating dialogue. In addition to participating in the question and answer session, I invite people to complete the evaluation form. The forms were on the tables as you came in and will be on the tables as you exit. You may notice that some of the forms, the topic for the grand rounds was not updated. The topic for the evaluation forms still says gun violence in Philadelphia, which was the topic of our last public health grand rounds. Please ignore that and fill that out anyway for this grand rounds, which was preventing obesity in Philadelphia. I'd also invite everyone here to consider joining the College of Public Health section on public health and preventive medicine. You don't need to be a member of the College of Physicians to join the section. You don't need to be a physician to join the public health section. So I hope everyone will consider joining. Following the question and answer session, we will also have a reception in the room next door. I invite everyone to stay, participate, and engage in the dialogue that usually follows the grand rounds. Next slide, please. This is the last public health grand rounds of the 2017-2018 session. We have tentatively set up the topics for the 2018-2019 grand rounds, and we actually plan to have 4 different topics for that grand rounds. We only had 3 in the 2017-2018 session. The preliminary topics, which are subject to change, are listed there as alcohol as an under-recognized public health problem, an update on HIV and sexually transmitted diseases in the Philadelphia area, access to primary care, and hypertension prevention and control. Dates for these 4 public health grand rounds will be forthcoming shortly. Next slide, please. So remember, please fill out your evaluation forms and join us for the reception afterwards. And again, thank you very much for coming. Next slide. So it's my great pleasure to introduce the moderator for the Public Health Grand Rounds tonight. This is Dr. David Sarwer. Dr. Sarwer is Associate Dean for Research, Director for the Center for Obesity Research and Education, and Professor in the Department of Social and Behavioral Sciences at the College of Public Health at Temple University. So please welcome Dr. Sarwer.
So thank you, Michael, for that very kind introduction. For those of you who have never been at the college before or have never been in this room before, I've had the good fortune of being here a couple of times, both in the audience and also as a speaker, and I really encourage you to take some time as you're walking through and appreciate the history that's on the walls and that's in the corridors of this building and of the entire complex. It's really an amazing place. As I was walking up the staircase, I was reminded of feeling like I was in a museum in Europe or something like that when I looked at all of the portraits on the walls. It really is a testament to the history not only of medicine, but also of public health in the city and in our country. Like most academics, I find it very challenging to only say a few things, and because we're already off to a late start, I'm even more challenged to do so. But I want to say a few things about the obesity problem in the United States to put it in perspective for all of you who may be less familiar with the scope of the issue. It is a true public health crisis. Currently, over 1/3 of Americans are clinically obese, defined as a body mass index greater than 30, and another 1/3 of Americans have a body mass index between 25 and 30, making them overweight and putting them at risk for the development of obesity and the health problems that come along with it. Now, while many of us, when we think about our body weight, think about, well, how are we going to look down the Jersey Shore later this summer? The reality is that excess body weight is associated with a whole host of significant comorbidities that can end our lives prematurely. Equally sobering is the problem with childhood and adolescent obesity in our country. The numbers continue to grow, and quite discouragingly, there is little evidence to suggest that once you are overweight or obese as a child, that you will be able to successfully reverse that trajectory as you move into your adult life. And thus, we are challenged to find ways through a variety of different strategies to push back against this crisis. And I leave you with perhaps two of the most sobering anecdotes to this before we start talking about solutions. In the last few years alone, we've had government authorities who have said things, like the Surgeon General, who have said that obesity potentially, or has the potential, to reverse the increases in life expectancy that we have seen over the last several decades in American medicine. That despite all the advances, despite our status as being a particularly healthy country, although not perhaps the healthiest in the world, the reality is that obesity has the potential to compromise that. At the same time, while those of us who work with patients who suffer from obesity know the challenges of getting reimbursement for treatment, we know that from an economic perspective, if the insurance companies were to take on the treatment of obesity the way they do for other comorbidities, it has the potential to bankrupt our economy. So we are kind of caught between the proverbial rock and a hard place, that we have a problem that's going to threaten our longevity and we don't have clear-cut solutions. Now, let me try to be a little more optimistic. Fortunately, we have 4 people from the Philadelphia area who are going to talk a little bit this evening about some of the local programs that are taking place on a variety of different levels to truly get us to think about strategies to push back. And I would encourage all of you to think, as we consider this topic tonight, that this is truly one of those phenomena that will take a village. There is no one right answer to the obesity problem in the United States and around the world. The reality is there probably are many answers that need to be used in conjunction. So with that being said, let me introduce our first speaker, Dr. Cheryl Bettigole. Cheryl is the Director of the Division of Chronic Disease Prevention and Get Healthy Philadelphia in the Philadelphia Department of Public Health. I had the great fortune of meeting Cheryl several years ago as I moved into my position within the college, and she's going to talk with us tonight about some of the epidemiological issues that we face in Philadelphia and some of the drivers that we see here locally. Cheryl?
I'm short. Thank you very much. It's a real honor and a pleasure to be here with you all tonight. And can I just say, the fact that there's at least 100 people who turned out to talk about a public health topic on a rainy night, thank you all. I was really struck as I watched people come in, how many people in this audience that I know are actually part of the village that's doing this work. So I just want to take a minute, if in your daily work or in your volunteer work, somewhere along what you do, you are part of solving this problem. Can you stand up for a moment? I know there's more of you. Just a round of applause for all of you. Thank you. And I hope as we go through our slides that for those of you who aren't yet part of the solution, that you're thinking about where's the right fit for me? How can I take action on this? So next slide. So I want to start by talking about where we are now and then talk a little bit about how we got there. This is a graph from a new Public Health Department chart that actually came out this afternoon, about an hour ago, so it's very fresh. With thanks to the Health Department's Chief Epidemiologist, Renard Washington, who put this together. This is a slide of the BRFIS data for Pennsylvania, for Philadelphia specifically, of adult obesity. And what you'll see, that dotted line there in the middle is the citywide average. And I don't know if you can see the labels, but the black line is non-Hispanic Black city residents. The darker blue line is Hispanic city residents, and then whites are the bottom line. What we're looking at, there's a little, up and down, as you so often see in this kind of a graph, but essentially obesity rates in Philadelphia over this period seem to be flat, and that is new. So we're not really calling this a downward trend, although we're a little tiny bit hopeful there at the end, but at least we seem to have seen a flattening. We also really still do see higher rates among our Black and Latino population of obesity than among other city residents. But in all groups, we think we're seeing at least a flattening. Next slide. So this is the data for Pennsylvania and for the US, and I'll just remind you that the citywide rate was around 30%. You can see for both Pennsylvania and the US, really close to 30%, but you can see that the trend is still upwards. So, the good news there, I guess, is that we're getting closer to the national average, and the bad news is it's because they're doing worse, not because we're necessarily doing better. Next slide. So when we break obesity down, we look by gender and we look by age. We see that women are much more likely than men in Philly to have obesity, and that we see much higher rates among people in the middle to later years, 45 to 54 being our highest group, but still substantial rates in young adults, 27%, certainly much higher than it was 50 years ago. Next slide. If we look by income and by educational level, we see really pronounced differences. So people who are low income or who have a high school education or less, much more likely to have obesity than people who are higher income or have higher educational levels. Next slide. In this data, which is 2013, you see that Philadelphia, at least from the last year that we have comparison data for the other big cities, had a substantially higher rate of obesity than other large cities. That may be changing now if their rates are going up with the national rate. Next slide. When we look at childhood obesity, between 2007 and about 2013-14, we saw a small but significant decrease in childhood obesity, about 6.3%. And we think a lot of that had to do with the fact that the school district of Philadelphia has been really proactive in terms of thinking about healthier food, implementing nutrition standards, getting rid of fryers, getting rid of sugary drinks. But there's just a little hint in 2015 of maybe a slight rise, certainly not a fall. We're still doing the final crunch on the 2016 data, but that also seems to suggest a slight rise. So we have a lot more work to do for on childhood obesity. Next slide. When we look geographically in the city, those darkest patches, which are the highest obesity rates, are in our lowest income neighborhoods. So North Philadelphia, West Philadelphia being particularly at risk for high rates of obesity. Next slide. Similarly, diabetes, and David spoke about the complications of obesity being really what we're looking to prevent. Diabetes, of course, is one of the principal complications. Can you go back? Nope. Yeah, this one. So in our lowest income neighborhoods, rates of diabetes can exceed 1 out of 5 adults. So almost 20%, or in some neighborhoods, more than 20% of adults having diabetes. Next slide. This is a national slide, but it looks at what was the prevalence of diabetes way back, 1960, so almost 60 years ago. less than 2% of adults had diabetes, and almost all of them were over age 65. It used to be a disease of the elderly. And because diabetes wreaks its complications over decades, it wasn't that critical a disease. It mattered. I don't mean to say it didn't matter, but it didn't have the kind of devastating impact that we are starting to see now. When we look at what's happened over half a century, we've quadrupled, quintupled the rate of diabetes. And that's not a timescale over which evolution operates. The human beings alive today with that rate of diabetes are essentially the same as the human beings alive in 1960. Willpower has not changed. People's nature has not changed. So something else has changed, and I would posit that most of that is our food environment. There's, some differences in physical activity. There's, we do less physical activity in the course of our daily routines, but a lot of this is what we're eating and what we're surrounded with day in and day out. But this is an immense change, and this is part of that risk of decreased life expectancy that we're looking at. Next slide. So here in Philadelphia, you see a similar increase in diabetes. This is just from 2000 to 2014-15, maybe a little flattening in the last analysis in 2014-15. We really need another data point to know whether to call that a blip or something real. We're hopeful, but we won't really know for sure until we get the next set of data. Next slide. And to me, this is really what it comes down to. Early death from heart disease. Philadelphia's numbers there at the bottom, far higher than any of the other big cities. We are dying younger, and especially our low-income residents, our Black residents, are dying younger from heart disease. That is a direct result of this epidemic. Now, tobacco plays an important piece in this too, right? And we also have the highest smoking rate of the biggest cities in the country. But this is what we have to change. Next slide. So I wanted to put a face, or a sort of a face, to this so we think about this and what it looks like in real life. And these are a few stories from my time seeing patients in the city health centers, with people's privacy protected, of course. Because how this operates in people's real life is what we need to make a difference in. The first was a gentleman in his mid-40s who I'd been taking care of for a number of years, who came in for a visit to follow up on a hospitalization for a diabetic foot infection, in which he'd had to have the front part of his foot amputated. And he came in for that visit, and he had with him his insulin. He'd been able to fill all the fairly expensive medications he needed because he did have insurance. But his sugar was 410, and it should be at least under 160. Very, very high. And what he told me in terms of what he had to eat was he had mayonnaise and white bread in his fridge, and that was all he had until the end of the month. So we've solved the problem for some people. We still have some work to do on this, but for a lot of people, we can get them meds, but we can't get them food. And there's a combination of access problems there leading to that, but that's what we have to solve if we want to prevent all the cost and all the human cost of our epidemic. And then there was a 13-year-old who came in with her mom. Mom has diabetes, and the 13-year-old is already overweight, and her weight has just been steadily going up the growth chart. So 85th percentile, then 95th, then off the chart. The family has been going through a lot of stress, intermittently homeless over the last year, and I tried to have a conversation with her mom about food and what she was eating, and her mom gave me the clearest articulation of what food insecurity is and what it means to obesity and diabetes development that I have ever heard. I've got $2 for dinner, and that's mac and cheese, or me and the kids go hungry tonight. And I think, again, we have to solve that to change this epidemic. And finally, an 8-year-old who came in for a routine checkup with a mouth full of huge cavities and dark velvety patches on his neck that we call acanthosis nigricans, which is an early sign that diabetes is starting to develop in an 8-year-old. Remember I said it was a disease of people over 65. His mom was really frustrated with him because he kept drinking soda. He would just go to the fridge and pour himself a cup. He's 8 years old, he can open the fridge. And it would be really easy to kind of criticize this mom, right? Why do you keep soda at home? You don't want your child to drink it. Don't keep it at home. That's easy. But I think what this speaks to is how normalized drinking sugary drinks has become in our society, that people have them for lunch, they have them for dinner. They're no longer a treat. They're what you drink. And so it was kind of inconceivable not to have them in the house. And I'm looking forward to Christina's talk as she talks about how that may change in Philadelphia. Next slide. So what are the drivers? How did we get here? So there's the cost of healthy food. And that cost is in dollars. Fruits and vegetables are expensive, and they're often seen as an extra, right? You can have dinner without fruits and vegetables. And they're also costly in terms of time. For a lot of people, you have to take 1 to sometimes 3 buses to get to a grocery store that has decent produce, and then you have to prepare them. And although in theory you can eat healthy on a budget, right? We have all those nice articles about eating healthy on a budget. It takes a lot of time and energy, and often the same people who are trying to do that are also working 2 or 3 jobs. So we've mapped walkable access to healthy food and poverty in our city, and we have almost 350,000 people who live in high poverty neighborhoods and who don't have walkable access to healthy food. So that's round about a quarter of our city. And then we also have these things we have started calling food swamps, areas of our city that just have immense amounts of unhealthy food and marketing for unhealthy food, so that everywhere you go, you see signs for these things. Next slide. And it looks sort of like that. And the way I like to think about this, if I go into my kitchen at the end of a long day, and I've got to feed my 3 kids, and I've got to feed myself, and maybe I have to get to my other job tonight, and my kitchen is full of unhealthy food, we're probably going to eat that. I'm probably not going to go out to the store, get a whole bunch of vegetables and some whole grains and come home and make that, because I'm tired, right? And that's kind of what our neighborhoods have turned into. It's really easy to jump into that store and get, a bag of chips and a soda. It's a lot harder to go make yourself a sandwich with what? Do you have that in the house? Next slide. So that's our problem. I'm really excited to hear all the solutions we're going to talk about. But I wanted to talk about a few things we're doing within the health department, just to balance this a little bit, and also because you'll see that this is a drop in the bucket. And how am I for time? Okay, I'm just going to let you look at that then. There's a lot going on. Happy to talk at the reception about what we're doing about it, but I'm going to turn things over to other folks. Thanks very much.
Well, thank you, Cheryl, for that great start. And now I already know the first question I'm going to ask her, which is tell us about that last slide. Our next speaker is Dr. Christina Roberto, who's the Assistant Professor of Medical Ethics and Health Policy at the University of Pennsylvania. And Christina came to Philadelphia and to Penn right around the time that I was leaving Penn and moving across town to Temple about 3 years ago. And I can say, even though I'm not part of that community, that not only was the university very fortunate to get her, but we at the city were very fortunate to get her. She is an incredibly innovative investigator who's really doing a lot of creative, impactful work at the interface of behavior, psychology, marketing, economic principles. And I think of greatest interest and greatest excitement to me is we're going to start to hear a little bit about what the impact of the Philadelphia beverage tax appears to be and is likely going to be going forward as we push back against the obesity problem. So, Christina?
Great. Great. Thank you. So this is on. I think I'm going to walk around a bit. So it's wonderful to be here. I'm really delighted. Thank you for the lovely introduction. It's an honor to be with this panel. And we have to give a huge shout out to Cheryl and the Department of Public Health. I think we have just one of the absolute best departments in the country, and they're really saving the city. And so thank you so much, Cheryl. Yeah. So the work I'm going to be talking about today is about the influence of the Philadelphia beverage tax, and this work is in partnership with the Department of Public Health. Ooh, well, that's fine. And I just want to give a shout out also. So Hannah Lawman is a very close partner on this, is one of my co-principal investigators, and Sarah Bleich at the Harvard School of Public Health, and we have a whole team of really terrific folks working on this. So let's start just so we're all on the same page about what is this tax. So the tax was passed, it started on January 1st, 2017. It's a 1.5 cent per ounce tax on sugar and artificially sweetened beverages, which makes it a little bit different than some other taxes that I'll talk about in a moment. I want to make sure everyone understands the way the tax works. So this is a tax that's on beverage distributors, right? And then what has to happen is a store has to decide how much of the tax they're actually going to pass on to the customer, if any of it. So one version is a store could just absorb the tax. Another is they could say we're going to pass it through and raise the prices of our beverages accordingly. There's even a version where they could actually raise prices even more than a tax. So one research question we have is just what's happening to the change in prices. Okay, let's go to the next slide. Okay, so before we get into these downstream or direct health effects and what's happening to behavior, the tax was actually motivated not necessarily from this obesity perspective, but to raise revenue for a variety of different programs in the city that, irrespective of the effect on weight, could be these really critically important programs. And so it's things like expanding universal pre-K, a community schools program, rebuilding community infrastructure, so libraries, rec centers. So a whole host of really good reasons to do this, again, independent of the effects on health, but we'll talk about those effects today. Next slide. Okay, so there are a lot of statistics and facts and figures, and our first two speakers did a really nice job situating this in the data in terms of why we care. I have a short little video that helps me sort of remind me emotionally when sometimes I just hear all these statistics and it's hard to connect to it in the real world. So I thought I'd just play this to kind of remind us why are we doing the work that we're doing, and that'll set us up for the tax research. Can you just click on that video button? It's right in the center. Yeah, thanks.
I probably would make a time machine. I would make medicine for the sick. I'd probably invent something new.
If
I could have an extra 5 years to live.
You said 5, right?
5 years. It's a long time.
I would try to fix everything I did bad.
I would bring my uncle back because I miss him very much.
I would get more hamsters.
I would probably want to go looking for dark matter.
I think I'd go looking for aliens.
If I could live an extra 5 years.
I was thinking about making like a helicopter, like a wooden helicopter, but I don't have any wood.
I want to go check out the moon sometime. I'd probably teach my sister not to hate tuna.
I would try and invent a machine that lets you run at light speed.
If I had 5 more extra years to live,
I would be the boss of all the chipmunks.
eu cantaria na frente de 1 milhão de pessoas.
I don't really know. I think I'd do anything. Why are you asking me that?
Okay, so I just wanted to kind of connect emotionally on this to sort of set up why do we want to have these policies? I mean, we're hoping that we can address that very problem that both Cheryl and David talked about. Okay, so let's get into the beverage tax work. So beverage taxes are starting to catch fire around the country. So Berkeley was the first, then Philadelphia, and there's been a few others that have sprung up. And so this is a map of the existing taxes, and some of these, they vary in terms of the amount. So you can see some are as low as 1 cent, and some go up to 2 cents. And Philly is unique in that we're the only one that is taxing artificial and sugar-sweetened beverages. So there's really an open question on what's the right way to design these taxes. Okay, next slide. All right, so I want to start with why are we particularly focused on sugary drinks as opposed to lots of other unhealthy foods that we overconsume. And I want to make the case that I think sugary drinks are a particularly important culprit to target. So we've got this slide here. You wouldn't eat 15 packets of sugar, and that's how much is in a 20-ounce soda. Next slide. And so the question I'm posing, it is on the next slide, yes, is why are we drinking them, right? So a few things to think about. First, there's a lot of good research now that links sugary drinks with a whole host of different kinds of health, negative health outcomes. They're the largest source of added sugar in our diet. They basically have no nutritional value, right? All the calories are coming from sugar. And there's evidence that they actually don't keep us full as long as the same calories in food. So I think sugary drinks are a special case, and there is a reason to target them specifically. Next slide. Okay, so the tax is doing that. And it's doing that by increasing the price. And the hypothesis we have is quite logical, right? If you increase the price, we should see a decrease in purchases of these drinks. And in this slide, if we're assuming 100% of that tax is passed through, remember we talked about it as a tax on distributors, the stores have to decide to pass it through, then this is the kind of price increase we would be seeing on these products. And they range obviously based on the size, but you can see, especially on these larger size drinks, it's a fairly substantial increase. And so we would expect to see some effect on behavior. We certainly see that with tobacco taxes. Next slide. Okay, so a little bit of background in terms of how this rolled out. So I thought the city did a really nice job. They had a whole host of different outreach efforts. So hiring a professional communications firm, putting materials together in lots of different languages. They did over 8,500 visits to stores to make sure they understood what was happening with the tax. And they have a website, phillybevtax.com, which you can go to and check out. And actually on the next slide, you'll see a shot of it. There we go. And so this just has a lot of information. So this was laying the groundwork for the rollout of the tax. Next slide. Oh, next slide. There we go. Okay, so a little bit about what's happening legally with this. So this is a legal timeline in terms of when the law was passed. That was back in 2016, and there's been a series of different, so there's lawsuits and court cases, and the tax has actually been upheld at a few different stages, and right now the PA Supreme Court has agreed to hear the case. And the quick version of this is essentially an issue of double taxation. So retailers in the industry are arguing Pennsylvania has a sales tax, right? And so it's against Pennsylvania law to tax something twice. And the argument on the other side is, but we are not implementing another sales tax. This is a tax on distributors. And then, again, the store owners decide to pass it through. And so that is the legal issue that's at hand, and we'll have a decision for that. I'm assuming it'll be, I think Cheryl was telling me it'll be a few months still, but that's happening now, just so everyone knows. Okay, next slide. All right, so that's some background on the tax. Now, I'm a researcher. I direct the Psychology of Eating and Consumer Health Lab, and we care a lot about how these policies influence behaviors. So we have a few questions we're trying to understand. So first, how does the tax influence prices? I was talking about pass-through. Second, how does it influence volume sales of beverages, both taxed and not taxed beverages? Third, how does it influence total sales of the stores, right? We want to understand the impact on businesses. And then ultimately, in the long term, did I lose my mic here? Oh, sorry. We want to understand how it influences the health of the city. Next slide. Okay, so I'm going to share some very preliminary results from the first component of this project. It's a multi-component study, but for this part, what we did is we bought sales data. So we bought data to try to look at beverage sales in the major retailers in the city of Philadelphia. So these are mass merchandisers, pharmacies, supermarkets. And the way we structured our entire research program here is we're looking at Philadelphia and we're comparing it to Baltimore, which is a city without a tax, so that's our control site. And then we're also comparing it to 4 counties surrounding Philadelphia. And part of the question there is, people in Philly could hop the border, buy their sugary drinks across the border, and so we want to understand how much of that is going over to the counties, and so they're still getting those beverages anyway. So on the next slide, I'll show you some just sort of top-level results here. Okay, so what you're going to see here are the change in volume sales in chain retailers for beverages that are covered under the tax. This is preliminary, so this is 6-month data. It's not our full data set. We're going to publish a paper with 1-year results, but this will give you sort of a general flavor for how big we think the effect is. Okay, so at the bottom, oh, you jumped the gun, but okay, but stop there because there's a little bit of drama I have to build here. Okay. So at the bottom here, you're seeing time in months, and then on the y-axis, you're seeing volume sales. And what just came across the screen are secular trends. This is just, hey, here's people shopping. But just notice the colors, green for the Eagles. It's Philadelphia, so Philly's in green. Then you've got the counties in yellow, sort of right on top there, and then Baltimore, remember our control site, and that's in orange. Okay, then you're going to hit one line, and you're going to show you where the bev tax starts, and then hit it again, you're going to see what happens after. Yeah, so that's the drama piece. It's pretty dramatic, right? So, you know, we expect it. It's a tax, and it's really, really decreasing the volume of these beverages. You see this little uptick in the counties. What this is showing you is there is some of this cross-border shopping that is happening. It is not nearly as much to offset this sort of dramatic decrease we're seeing. Okay, on the next slide, I'll quickly show you what's happening to beverages not covered under the tax. Yeah, so that's about the percent drop. Okay, all right, so let's see the secular trends. These are beverages that are not being taxed. We're wondering what's happening to them. So you can hit the button and that'll come across the screen. Okay, and then I think the tax starts. I think that should be, yeah, tax starts and basically, yep. And we're actually not seeing anything, right? The patterns look the same across the different sites, so not too much change there. And then I'll show you one more bit of data on the next slide. So this is just broken down with sugar-sweetened beverages and artificially sweetened beverages. They're both taxed, and we're just curious if the effects are different. And so if you let the data roll, you'll see what's happening to those over time. The dotted ones are artificially sweetened. And yep, tax starts. Yep. Yeah, so similar, very similar patterns. Obviously, artificial sweetened beverages make up a much smaller percentage of beverage sales, but the same thing's happening. Okay, next slide. Okay, so those are just some top-level early results. It's interesting to see some of the retailer reactions to the tax. So what's happening around the city, I'm sure you've noticed, is there's been different signs that have been put out. One of my favorite pizza places around the corner had a sign, I think it's on the next slide, and it basically said, price of soda is going up, drink more water, smiley face. So these signs are rolling out in different ways, and I point them out because I think it's interesting. I actually think, I understand why stores are doing this. They're like, look, it's not us. This is why we're raising the price. But I actually think it's making the tax more salient, and it's potentially increasing the effect of the tax. So I think that's interesting to think about. Next slide. Okay, so I'm going to end by just telling you a little bit more about the work we're doing, and stay tuned for papers that we'll be publishing in the next couple of years. So we wanted to understand how the tax was influencing small stores. What I showed you was from big, large retailers. So we actually went out before the tax and did thousands of interviews with people at small stores in Philly and in Baltimore, where we stopped them as they're coming out of these stores. We wrote down everything that they were actually buying, and then we did surveys where we were asking different questions, knowledge about the tax, beverage perception. And so we're looking over time to see how their purchases at those small stores have changed. And then the last component, the next slide here, is a longitudinal study where we actually recruited 300 people in Philly and 300 in Baltimore. And we asked them, so we got them before the tax, and we asked them to text us and mail us all their food-related receipts and then do some surveys. And so they've now done that at baseline, and they've done that a few times afterwards. And we have this wonderful, like, 87% retention rate. So we're really excited because this is really the strongest study design where we're following the same people over time and seeing how their behavior changed. And the last piece is a qualitative, some qualitative interviews we've done with store owners to understand their perspective on the tax. And then we've come back to them a year later to kind of debrief and get their opinion on how things are going. So this is my last slide. I'll leave you with some beautiful peaches, and thank you, and I'll be excited to answer questions during the panel.
Thank you, Christina. Thank you for sharing that video with us. It's far more impactful than me trying to quote the Surgeon General's warning, and I think illustrates the point more elegantly. But also, thank you very much for sharing all that with us, because I think for those of us who follow what's going on in the newspapers and the mass media, it's nice to see a little bit behind the curtain of what's happening and what's likely to happen next. So our last two presentations are going to be a little bit more specific examples of programs throughout the area that are having a nice effect on changing people's behaviors. And our next one will come from Chinwe Onyekere. She is the Associate Administrator at the Lankenau Medical Center and System Administrator of the Graduate Medical Education of Mainline Health, who will talk with us about their program looking at population health in action and intersection of food, health, and obesity prevention.
Good evening. It's such an honor to be here with you and on such a wonderful panel. So I'm really eager to talk to you about some of the work that we're doing that's taking all of the powerful data that you just heard and trying to think about how you can leverage the power of healthcare and a healthcare system to address those issues head on. Next slide. So I think it's really important for us to think about geography and the power of place. I grew up in West Philadelphia. I work at Lankenau, and the power of place, I think, is really key to the work that we're doing and the diversity of our patient population. So we literally, Lankenau Medical Center literally sits on the line between Montgomery County and Philadelphia County. We are in Montgomery County, but right across the street, City Ave, used to be called City Line Avenue for folks who grew up in the area, and so right across the street is West Philadelphia. And so we have patients that in Montgomery County, as you can see in the dark green there, has a median income of over $100,000. You literally cross the street into West Philadelphia, and the median income drops to about $25,000. So the diversity of our patient population, I think we see that as an asset, as a way for us to be compelled to think innovatively and creatively around how we meet the targeted needs of our patient populations. And so some of the programs that I'm going to describe is in that opportunity to think about that in a different way. Next slide. So if you look at the county health rankings, that link between income and health, I think, becomes even more stark and visible. So again, when you look at health outcomes, mortality and morbidity, through the county health rankings for the past 6 years that's funded through the Robert Wood Johnson Foundation, Montgomery County has been about 4, has gone up to 3, but about 3rd or 4th in this state. There are 67 counties in Pennsylvania, and Philadelphia County has remained at 67. Now, when you look at health factors, that disparity becomes even greater, with Montgomery County ranked number 1 versus Philadelphia County, which ranked 67 out of 67. So again, a direct link between the income and the health outcomes, and so we wanted to think a little bit differently of how do we address this. Next slide. So one of the major impetuses for us to think about how we are doing our work was related to our community health needs assessment. Every nonprofit hospital across the country, through the Affordable Care Act, conducts a community health needs assessment. So these were our top issues that we decided to focus on for Lankenau and for mainline health. And one of the things that we really appreciated and understood was that across each of these areas, one, diet played and nutrition played a key issue area that we wanted to focus on, but also the issues related to social determinants of health. And so it was an imperative for us to think holistically about our patients' needs and identify them, work with them to address those needs within a clinical setting, and also moving beyond our walls into the community. Next slide. So this is my first and only Google Earth map. I was very proud of this Google Earth map. But it shows that Lankenau, again, the power of place, sits on 93 acres of land. And it used to be a golf course. And so we had this vision of really transforming. We know the power of the built environment, and we know that we wanted to create our environment to reflect our commitment to health and wellness. So one of the first things that we did was create a walking trail in the back. We call it kind of the back 40 acres, for anyone, staff, family, patients, to be able to walk on the trail and for physical activity, and as a place to kind of connect again to nature. And then the next effort was building a half-acre farm on our campus, which I'm going to talk a little bit more about. Next slide. So I want to walk through how we've leveraged the importance of nutrition, the importance of accessing fresh and healthy food within the clinical setting, within the four walls of the hospital, but also, most importantly, how we went beyond the four walls of the hospital into the community, leveraging partnerships with organizations like the Food Trust and the Philadelphia Department of Public Health. But I'm going to walk through that with this slide. With this, oh, yep, we can go to the video. Thank you.
In tonight's Health Watch. This is interesting. It really is, and it's helping so many people. You know, good nutrition is an important part of being healthy, and now, instead of just talking about it, doctors and nurses at Lankenau are harnessing the power of locally grown food to strengthen community health. Take a deep breath. After a checkup for blood clots at Lankenau Hospital, 34-year-old Zakia Sykes gets a special treat. Tomatoes, green peppers. I'll try green peppers. She gets to choose among a selection of fresh produce right there at the doctor's office. I love it. I love vegetables. And it's just that, especially getting like organic ones, they're so expensive that I just have to buy whatever I can afford to get. The produce is grown not on some farm far away, but in a wellness garden right next to the hospital.
We actually have a mixture of sweet peppers and some hot peppers.
In conjunction with a nonprofit called Greener Partners, Lankenau is growing all kinds of organic produce on a quarter acre, harvesting about 2,600 pounds year-round.
A variety of things. Diversity is the keystone of nature, so we try and do a blend of stuff that are both nutritionally dense, like kale and collard greens and Swiss chard, as well as things that are just good and tasty, like tomatoes.
The produce is given to needy patients being taken care of at Lankenau, and they also get pop-up education and recipe suggestions in waiting rooms.
We have some families that are only getting 0 to 2 servings of fresh fruits and vegetables a day, and many of them are also dealing with chronic diseases like diabetes and cardiovascular, cardiovascular health and diseases.
Chinwe, Onyekere, Associate Administrator at Lankenau, says not only will the free produce help patients eat healthier, it gets them talking and thinking about nutrition.
It's all about keeping our patients well.
Instead of just treating sick patients.
Exactly. It's about health care instead of sick care.
Health care instead of sick care. I love that line. And it's not just patients who benefit from this community garden. Thousands of students who visit the Health Education Center also go out to the farm to learn about healthy eating. So cool. It's right outside the hospital. You can be in the hospital, look at the garden, the farm.
There's a lot of excitement with Sophie's all there. So we can go to the next slide. So I think one of the things that's so powerful and exciting is that we're on a half acre, as I mentioned, but we're actually growing on about a 1/16 of acre because we're growing in raised beds. And I think sometimes we think, oh, we need a lot of land or a lot of free space to actually produce food. And we're about to hit our 3rd growing season, and we've almost hit 10,000 pounds of food on a 1/16 of an acre that we've given away to over 2,000 patients. And what's so exciting as well is that the work that we're doing in that waiting room is really, it's interesting to see, because when you know you're having the best classes, when the patients are talking to each other and learning from each other on how to incorporate these fresh fruits and vegetables into their diet. And at the same time is this idea of rethinking this idea of healthcare delivery. Well, why not at your doctor's office would you get, of course you would get fresh produce. And so it elevates the opportunity to have that conversation with your provider when you're walking in to the exam room with a bag of fresh produce for our physicians and our nurse practitioners to say, well, how are you going to cook the collards or the kale? Or do you know that you can also turnip greens, you can actually saute the turnip greens as well. It starts a dialogue that I think is pretty powerful, and that relationship between the provider and the patient is even enhanced. And so the idea also that from the time the patient walks into the practice to the time that they leave, that whole experience is focusing on their health. I'm trying to eliminate the idea of waiting room time. There's no waiting time. We're actually going to be focusing on the health of the patient from the time that they come in to the time that they leave. Next slide. So one of the other things that we've been doing, again, is trying to think about what we do within our walls, but what we do in the community. And so we've had the opportunity to think about the link between primary care and community and public health. Next slide. So in partnership with the Food Trust and with the Philadelphia Department of Public Health, Lankenau was the first health system to leverage their community benefit dollars to purchase Philly Food Bucks. So we've purchased Philly Food Bucks that we provide a packet of $10 worth of Philly Food Bucks to our patients, and that they can use at over 25 farmers markets in Philadelphia. What's so powerful is that in addition to providing our patients with the Philly Food Bucks, we've also embedded it into our electronic medical record. So we can link the redemption of each Philly Food Buck to the patient. As you can see in the corner, there's a serial number on each Philly Food Buck. We capture which Philly Food Buck is linked to which patient. And in the last year, we've given out about 1,700 Philly Food Bucks. We have about a 30% redemption rate, and so we know which patients have redeemed, and not only which patients have redeemed, which market that they've redeemed, so that that can inform us where we can do more targeted outreach at the farmers market. But what was also really interested, we're also thinking about how we can leverage our Philly Food Bucks outside of the clinical practice. So we're in partnership with the Free Library of Philadelphia, and we're in all of the 5 branches in West Philadelphia. So at the Haverford branch, we just started last year, we've been providing Philly Food Bucks. So what's so powerful is that we selected that library on purpose because we also have a partnership with Spectrum Health, which is it's a federally qualified health center about 5 blocks down the street, which is directly across from a farmers market. So we can basically provide the Philly Food Bucks, and then our health educators walk with the patient to the farmers market. They can redeem those Philly Food Bucks right on site. And so our redemption rate's about 75% for the library location. So we're trying to think creatively around, again, how we can bring these services together. And for anyone who doesn't have a primary care provider, we ask about that, and we can link them to a community primary care provider like Spectrum. Next slide. So the other partnership that we are working on with the Food Trust is around the Healthy Corner Store initiative, where the Food Trust has been doing some tremendous work really redefining and re-engineering corner stores into healthy corner stores and linking them as distribution sites for healthy food access. So we thought, could we bring our health educators into that space and have that serve as a portal for connecting patients to screenings and health information. Next slide. So what we have found is that the corner store is an amazing way to connect with some of our most at-risk patient populations that potentially have received primary care, and then link them to primary care providers. So we're seeing a wonderful representation of the community within the corner store, and that's what this slide represents. Next slide. So we are really in the corner store. This is Helen, one of our health educators. It's amazing what you can do in the aisle right next to the kitty litter, but you can really do some amazing work right in the middle of the corner store. So we do blood pressure screenings, BMI. What we've been able to do is track each participant as a unique participant and then trend their data over time. What has been so powerful is that, our health educators are developing relationships with folks in the community and participants in this program. So we have about a 46% repeat participant rate, that 46% of the participants are coming more than 2 times to the Healthy Corner store to get their health information, their BMI, and their blood pressure screening. And so with that information, we know that about 36% of our patients have seen a decrease in their weight, and we've also seen a significant decrease in blood pressure screenings. We've done, in a very short period of time, over 196 people have been screened, and with 345 screenings. Next slide. The other program I just want to end on is the work that we're doing with our Medical Student Advocate Program. This is where we are in a partnership with the Philadelphia College of Osteopathic Medicine, where we have second-year medical students that are a core component of our patients in our medical home team and our residency practices. And the work that they do in partnership with our clinical team is that they are experts in identifying and addressing social determinants of health within the clinical setting. So they identify social needs, they connect our patients to community-based resources, they created a wiki, now we're going to turn into an app of over 800 community-based resources, and with the power of kind of crowdsourcing of the medical student advocates, it's continually updated and refreshed. And then they're able to connect our patients to those community-based resources and track resolution. All of this, again, is embedded within the electronic medical record, and we're able to track for every patient that has identified a need, if the need has been resolved, unresolved, and then link that, hopefully, in the future to seeing any trends and outcomes with health outcomes. Next slide. So I just wanted to give a bit of a look at the social needs survey. So we created this questionnaire for all of our patients within, again, kind of rethinking the role of the waiting room to identify social needs. But the two questions we embedded, and we ask everything from transportation to childcare to job training. And at the top, we focus on food insecurity. So we've asked the two-question screen around food insecurity, and we're able to then connect our patients to those community-based resources. And so this is a quote that I think that's really powerful for me because it represents the work that we're trying to do. We're really trying to imagine a healthcare system that couples treatment with care and considers the life needs of patient, families, and caregivers inside and outside of the clinic. Thank you so much. I look forward to your questions.
Thank you, Chinwe. I think that it's a really elegant example of how hospitals and health systems can think more about, as you said, more about health care than sick care, and really be more proactive in going out into communities and neighborhoods to promote health rather than just waiting for people who become more critically ill to come to us when they truly need help and we don't have an opportunity to meet earlier. So our last presenter tonight is going to give us another great example of things that are going on in the Philadelphia area. This is going to be Heather McDaniel, who's the founder of the Amethyst Consulting and former executive director of Students Run Philly Style, a really unique program that has encouraged children and adolescents around the city to engage in running as a way to promote physical activity. Heather?
Okay, am I on? Am I echoing? Okay. Well, thank you so much for having me. It's a pleasure to be here again with this great panel. And I'm here to talk to you about something that I was asked to do 15 years ago that seemed impossible, and many people told me, in fact, was impossible. Next slide, please. So for those of you who don't know what this is, actually, anybody besides Michael Sachs know what this is? Where this is? The Art Museum. Do we know what day it is? Go ahead, tell us, what day is it?
Marathon staging area.
There you go. It's the Marathon staging area. So if I were to tell you that I could get 400 students in Philadelphia, 400 teenagers, to line up on the Art Museum steps at 5 o'clock in the morning, would you believe me that I could actually do that? No, right? That would be impossible. There would be no way that we could do that. Okay, so 15 years ago, I was asked by the Robert Wood Johnson Foundation and the Independence Foundation, who's a co-sponsor tonight, to build a program in Philadelphia's most underserved communities to address the childhood obesity problem that existed. And we already know all the statistics. We heard all of the status of obesity in Philadelphia. We knew that something needed to be done. And so that idea of what's impossible. So how did we do this? I'm going to tell you first about a story about a young man named Roy Bowser. Roy Bowser was a junior at Saul High School in Roxborough when I met him. He had obesity. He was already diagnosed with childhood obesity, and he wanted to join the Students Run Philly Style team at his school. Students Run Philly Style is a mentoring program that uses long-distance running to reveal the inner strength that we believe every young person in the world has, but certainly that every young person in Philadelphia has. And so Roy was training with his mentors, and we do a whole lot of, this is volunteer powered, so we have over 200 people in Philadelphia that serve as mentors, and they get training through us, and they get training in trauma-informed care and all kinds of things. He was training with his mentors, and we were preparing for the 10-mile Broad Street run. He got up to about 8 miles, and we were a little concerned about his knees and whether or not he could complete this distance. But he really, really wanted to do it. And so we talked to his coaches and said, okay, if one of your parents comes along the race course in case something happens, because we were also had literally like 800 other students that we were managing that day, that would be fine. Go ahead, we'll come along and do the Broad Street run. So the end of the race is there, the clock is coming down. I'm at the finish line, I get a call from the race director, Jim Marino, says, Heather, I think I have one of yours coming down the pike. Next slide, please. So what I had was Roy Bowser, who was about to finish the 10-mile Broad Street run. He had 25 of his closest friends jump onto the race course with him. All those kids in the blue shirts had already finished the race. They jumped on with him. Were you there? Do you remember? You remember. Bring her back. Okay. And collectively, they run across the finish line of the 10-mile Broad Street run. There was not a dry eye in the place. I had Jim Marino and Peggy, if any of you know them, all of them weeping, because is there anything more motivating than this? Than a young person who now believes that they're a rock star because they are? Let's go to the next slide. So fast forward to a couple months later when we gather our community of people and we honor them. Next slide, please. This is Isaiah Smith. He's actually a rock star. I mean, if you met him, you'd be like, yeah, you're a rock star. But he's by the time he graduated from high school, he was a 3-time marathoner, probably ran 4 or 5 half marathons. He was the kid that everybody in the program looked up to. So we're in North Broad Street at a center there where we're having our appreciation event. Isaiah stands up in front of literally 400 people and he looks across the room and he says, Roy, you are the person I admire more than anyone in this room. For me, running comes easy. I can do it. It's not a hard thing for me. But for you, you earn every single mile that you have. That medal that you wear, you earn it, and you earn it hard. Again, not a dry eye in the place, right? Because these are rock stars talking to other rock stars. So I share with you those stories because I believe that the way that you build solid public health programs is by building a community that people want to be a part of, especially when you're talking about teenagers. There's no way that you can get, I mean, people told me it was impossible. You're going to get kids to run a marathon, right? Most people think it's impossible anyway. And lucky for me, I didn't really care what everybody else was thinking. They also said you're never going to raise enough money to actually be able to support it. We're now in the 15th year of Students Run Philly Style. Over 6,000 young people have gone through our program. Next slide, please. Consistent outcomes over time. We consistently showed a decrease in body mass index, improvement in cardiovascular fitness, awareness of a healthy lifestyle. That was done in partnership with Drexel and with Temple. And the most recent studies are showing 60% of our students are active for 60 minutes. And 5 to 7 days a week, okay? So we already know, we outlined the problems. We know that that's way more active than the average person in Philadelphia, right? All right, next slide. And so I believe in evidence-based practice, but I actually really believe in practice-based evidence. I get 450 teenagers to stand on the Art Museum steps at 5 o'clock in the morning. The Sunday before Thanksgiving. I think that's evidence, right? And our kids run 600 miles a year. But 2 weeks ago it was a Broad Street run. 900 students completed that. Over 1,200 enrolled in 55 schools across the city. We now serve kids in every single zip code. Next slide. So how do we do it? How do we actually put this together? How do you form an organization that kids are going to respond to and be part of? Well, one thing is branding. You have to know what the heck you're doing around branding, right? So colors matter, that kind of, if you run a marathon with Students Run Philly Style, you earn a hoodie. We redefined what it meant to be a young black man in Philadelphia wearing a hoodie, and I am really proud of that. There is no way to get a hoodie. You can't get it on eBay. You can't buy it from anybody else unless you run a marathon. So that's one thing. So build something that matters to the young people you're working with. We also have 3 stated values, the program values, and they start with courage. Right here is a young gentleman named Jason Foots. Jason had the ring around the neck. The clinical term is, I won't be able to say that, but he had the ring around his neck that showed that he was about to get diabetes. He was 11 years old. When he turned 12, he was able to run with Students Run Philly Style. He was on the childhood obesity charts. 6 months later, he was off the charts. He went to his pediatrician. They couldn't even put their heads around it, how this all happened. But it happened because he was part of an organization that he wanted to wake up on Saturday mornings and go run with them. Next slide, please. Here's Jason, a 21-year-old, college, about to be senior with his family. I hope you noticed those New Balance there in the corner, because the entire family lives and dies by the organization. Next slide. The second program value is effort. The young woman in the middle there is from an immigrant family from Cambodia. I'm also really proud of the fact that I got into Sports Illustrated before my nephews, who are really good athletes, because we had a story about her cousin that was written by one of our parents, who's a Sports Illustrated writer, but about the fact that when their family immigrated to the United States, to Philadelphia, they ended up eating, the young kids were eating Hot Pockets and doing that video game Halo, like literally 12 hours a day. So we have 2 teenagers playing Halo like 12 hours a day. Okay, do the impossible. We get them involved in Students Run Philly style, and go with effort. Put the effort to get to the starting line, because if you get to the starting line, you're going to get to the finish line, because we're really good at getting you from point A to point B. So we have courage, and we have effort. Next slide is respect. So this is Nadia Sanchez. This one kind of chokes me up because I love how proud she is from where she comes. And she's finishing the half marathon, in the Philadelphia half marathon. She's got cardiovascular disease on both sides of her family. She is changing the course and the future of her family's health. So courage, effort, and respect. Next slide. So I mentioned to you some of the outcomes we had over time. We're now involved in some really interesting research, a new study direction about the early effects with Chris Fringillian from CHOP, the early effects of trauma and what physiologically happens to our bodies with trauma. I'm sure many of you are aware of the relationship between early trauma and obesity, early trauma and diabetes. And we're looking at toxic stress and how a model like Students Run Philly style can actually start to reverse the cellular effects of early trauma, which I think is really interesting. And next slide, please. So a couple more elements to what I believe make a successful public health program. That, again, in this population that's impossible to reach, right? Teenagers, is create community, something they want to belong to. So hopefully you see the green up there, right? So it's either blue or green. And you have kids, so not only is this an obesity prevention program, it's a violence prevention program, it's a pregnancy prevention program. But we'll have kids from North Philadelphia that'll see a kid in a Students Run shirt from West Philadelphia, and all of a sudden they're on the same team. So the collars that went up back in the day are no longer there, right? So it's violence prevention. But creating community has been extremely important. Next slide. And then the whole focus of this organization is on mentorship. It's on providing an adult, a caring adult, who shows up over and over and over again for a young person who oftentimes has had people left them over and over again. And our mentors, I just have to say, are unbelievable people that spend literally like 15 to 20 hours per week mentoring our youth. And the mentors, next slide, never give up. On the right-hand side is our very first marathoner. When he was 16 years old, he had a brain tumor. And his doctors and his family and everybody around him said, are you crazy? You're going to run a marathon? You want to run a marathon? It's impossible. And he said, I don't care what you think. And this young gentleman on the left was his minister at his church and said, I don't care what the doctors say. I'll talk your parents into it, and we're going to run a marathon. And 9 months later, Travis Shank crossed the finish line of the Philadelphia Marathon. He is now a cancer survivor, a college graduate, and a marathoner. And I hope you noticed the New Balance in the church pew. And the next slide. So we went from 4:30 in the morning. This is now 6:45-ish. And these 3 young people are going to walk down the steps, and they're going to go to the start line of something that's going to change their lives forever. So we're addressing obesity, yeah, but we're doing a lot more. We're giving young people the ability to see all the strength that they have within, and that no matter what life throws at them, no matter if it's a corner store that has too much sugary foods, or if it's a different type of trauma that comes their way, they're going to have all the strength within to address it. And then they'll be wearing that hoodie there on the right, and they'll have the pride forever. So thank you.
Well, that was far more inspiring than my remarks of gloom and doom to start the evening, wasn't it? Let me invite our panelists to come on up. We have approximately 10 to 15 minutes for question and answers. And to follow Heather's lead a little bit, what I'm going to ask all of you to do, I don't necessarily know the customs when we get together like this as a session, but for those of you who ask a question, I'd encourage you to come up and use the microphone. But I would also ask that you take a moment to introduce yourself and to say what program you're from or what health department in the city you're from, because I think if we're really going to grow our sense of community as public health professionals, it's good that we use this as an opportunity to get to know one another a little bit. And if you guys don't ask questions, I'll dominate the time.
Thank you for this opportunity. I really appreciate it. Can you hear me? My name's Bridget Morse. I'm not here in a professional capacity, but I do work for Back on My Feet. That's similar to students run Philly style. I'm sorry, I'm a bit nervous. It's a really exciting lecture. I have two questions. It doesn't matter if you answer any of it, but I was curious about the long-term outcomes for the students with Philly, if you guys are able to track that. And the other question I have is, I recently lost 60 pounds, and I could not get help from my primary physician. I was lucky enough to luck into a program at the University of Pennsylvania. So when I did ask my physician for help, he said, you need an appetite suppressant. And when I had success with that, I went back to him and I said, well, can you prescribe this? He's like, there's no way in hell, you don't need this. It is, even though I had success on it and I was on it for a year, he said, you can get another primary physician. And I've just found that it doesn't matter who is obese, when they go to their GP or their pediatrician, they always want to hand them off to a nutritionist or a specialist at CHOP, whereas I think some of these families and some people like me would also benefit from a little bit of medical help. Speaking of obesity in children, I mean, some of these families just honestly don't know what a healthy diet is. Or how much should I feed my 8-year-old? Things like that. So feel free to address either ones. I really appreciate this lecture. Thanks.
Cheryl, do you want to take the part about working with your primary care physician and touch on that a little bit, and then we can talk a little bit more about outcomes related to some of the programs we've heard a little bit about?
Sure. Primary care physicians are human beings like everybody else, and I think not every match is perfect. So some of this is about finding the person who you feel comfortable with, who you feel is listening to you. I do think that there is really a place for the skills of nutritionists. They can be a really helpful adjunct to primary care. So I don't think that's, I think there's ways to refer to a nutritionist that can feel like you're being pushed off, and ways to have it feel like a team.
And so the long-term benefits of students run Philly style, if you are you asking the question whether we're tracking alumni? Okay, so we are currently not tracking alumni in a quantitative way, only qualitative.
Hi, I'm Jocelyn Wainwright. I work for the American Association for Cancer Research, and I'm a health policy student at the University of Sciences. I'm wondering about BMI as an indicator. Obviously, it's an indicator for obesity and overweight, but as you're aware, as we're entering the era of personalized medicine and relying more on genetics and genomics for personalized medicine, personalized care, do you think that it is that BMI is at an actual legitimate risk of being considered not a reliable factor to indicate a person's health, or to use it as research data? And could that actually be a potentially good thing, because we'll use more personalized care for patients and see other factors that affect their health in that way?
So I can start it. I might turn a piece of it over to David, actually. BMI is very useful from a public health point of view. There are certainly people for whom BMI is not an accurate measure, often particularly people with very high muscle mass. But as a population measure to tell us how we're doing from a public health point of view, it is quite useful.
So it's an insightful question, and I think it's one that people often ask about, because not only do we think about it in the context of precision medicine and the potential that that may bring, but people will also talk about it in terms of waist circumference. And some former colleagues of mine at Penn wrote a position statement a few years ago that said, in reality, measurement of waist circumference is probably a better indicator of weight-related health concerns than BMI for some of the reasons that Cheryl alluded to. I often, though, think about this a little bit getting back to the first question, which is, what types of conversations are patients and providers having around issues of weight? When I started working in the field 20 years ago, if we were a room full of physicians and I said, how many of you are calculating your BMI in your patients, nobody raised their hand. And it took us several decades to get physicians to more regularly assess BMI. And so for many of us who've been fighting this battle for a while have said, well, that was a victory that we won. But now we are thinking, well, what about waist circumference? And then we have scientists who are saying, well, maybe it's precision medicine and genetics. And I am a little bit sanguine about that, because I think that while BMI is not a perfect tool, and it's probably at its strongest when we think about it from a public health perspective, if nothing else, it gives us a platform to start the conversation between a patient and a provider around weight control, which still to this day doesn't happen with the frequency that it should. So even though we've been effective in getting physicians to calculate it and drop it into an electronic medical record, now I think our next challenge before we pivot to what's the promise of personalized medicine is, how do we do a better job of training the next generation of physicians to really take this health issue head on? Because we know that medical schools are still woefully behind the curve when it comes to educating the next generation of physicians on how to deal with issues around nutrition and promote preventative health.
Thank you.
Yes. My name is Jim Pectorell. I'm a community public sector psychiatrist here in Philadelphia. My question's around the artificial sweetener component, and in a couple different ways. One is, I'm wondering if the cities that had the beverage tax that didn't include that, if their statistics are a little bit different, and I guess the other thing is what your take is on if artificial sweeteners are maybe not ideal, but sort of from a harm reduction point of view, worth advocating compared to sugary drinks. I know a lot of people have sort of superficial or superstitious ideas about that. So,
yeah, it's a very interesting question. It's a good point you raise. And I think, there is the reality of the state of the science right now does not show a clear negative link where, if you consume more artificial sweeteners, you're actually going to be more likely to gain weight or negative health outcomes. And so there's actually not data suggesting that these are harmful right now. But the absence of data doesn't mean that it's not the case. It could be that more research comes out, over the next few years, and there are some links. But if you look at that data, it suggests that this is not necessarily a bad thing if people are consuming it. Part of the conversation around taxing artificial sweeteners or not is also an equity one. And so there was some thought and argument and concern raised that, this tax is, if most of the burden is placed on folks who are lower income because they're higher consumers of these beverages, that's a worry. And so if higher income folks are more likely to consume artificial sweeteners, then taxing them will kind of even out that burden a bit. So there was a sort of like economic and social justice concern around it that is not part of the health question. But I do think it is an open health question.
Okay, thank you.
Hello, my name is Samantha Pierpoint. I'm from the Pennsylvania chapter of the American Academy of Pediatrics, and I work on the Epic Obesity program. And if you're not familiar with it, it's a program that brings a two-person team of a physician and registered dietitian on site to healthcare professional audience and teaches about issues related to pediatric overweight and obesity, particularly sleep, mental health, screen time, food, beverage. and if it sounds like I'm promoting it, I am. We've recently embarked on the discussion of food insecurity at the chapter and how we address it with healthcare professionals. And in doing that, we've come upon the discussion of the sugary beverage tax. And I spoke with a woman when we were talking about, people she's encountered. She worked at a food bank, and why they drink these sugary beverages. And one common thing she kept getting was they're drinking the 2 liters of soda because they can't afford food and it makes them feel full. So my question on that, and the reason that I have hesitancy with talking about, or not when talking about, but with advocating for the sugary beverage tax is, how do we redirect their attention to other beverages, as a community, and how do we teach them about sugary beverages while also implementing the tax?
Yeah, so how do we teach folks about other beverages while implementing the tax? So I hear what you're saying. That if I'm hearing you right, there's this kind of concern that, look, you're taxing these beverages when someone's in a really tough situation and they need some food for their family. This is sort of putting extra pressure on them, and this is an argument that it's kind of a regressive tax for that reason. I think the way I think about it is a lot of these diseases in my mind are regressive, right? And so they're disproportionately impacting folks of lower income. And so from that perspective, that's how in my head I feel like, I do think this is probably a reasonably good idea to kind of even out this disparity. In terms of educating, I don't know, folks might have other thoughts around what's being done at the city, but I know you guys have done various campaigns, and I'll let Cheryl talk about.
Yeah, so we've done mass media campaigns, particularly targeting caregivers of kids about the impact of sweetened drinks, because I think a lot of people think of obesity and diabetes and heart disease, et cetera, as adult problems. And one of the things I've always been struck by is the number of mothers that I take care of who tell me, well, I can't eat right for my diabetes because I have to cook for my family. Kids have the same genetics as mom. 50% of the genes of mom, their risk of diabetes is high, and it would be ideal if they started with a diabetic diet. So I think, that was part of the thought in targeting caregivers for those messages. But the other thing is that there was a really interesting analysis done by the Harvard Choices Project using modeling to look at the impact of the tax and whether it would turn out to be regressive or not. And what they found was that based on the price elasticity estimates, low-income folks would actually save money with the tax because the tax would have a greater impact on someone who was low income in terms of their purchasing choices. So they would purchase much less in the way of sugary drinks and therefore spend less. Also get less in terms of sugary drinks, but that overall they would in fact save money. Which I think adds to the regressive nature of diabetes in our communities in terms of just we expect that the overall benefit will largely accrue to our most vulnerable populations. But it's a really complicated area.
Yeah. Well, thank you all. I appreciate it, and I commend you for what you're doing.
So let me ask, we're running a little bit long on time, but let me ask our last 3 questioners to try to be concise with your questions in the interest of time so we can all enjoy the reception.
Hello, I'm John Spiegler, a graduate student in public policy and political science. So I kind of wanted to address where the problem is and how you target it. It seems like when you were talking about the issue of food and its relationship to obesity, talking about supply problems, like there's not enough food in the areas that people need it, or it's a price problem, people can't afford it. But then when you talk about the sugary beverage, it seems like the solution there is to target demand. You tax a sugary beverage, that's ideally passed along to the consumer, and so they consume less of it. So I wanted to ask, why don't we take the target of demand that we see with sugary beverages and apply it to the demand for food as well? It seems like those two things, it's the same issue. The beverage causes obesity, the food causes obesity, but the solutions are, far apart from each other. So I just wonder if you could address that issue.
So are you suggesting, like people have said, hey, we should have a junk food tax? Like why just focus on sugary drinks? Yeah. So certainly people have raised that, and I share your view just from basic economics that sure, if you tax junk food a little more broadly, you'd probably see even bigger effects in terms of health impacts. And there are countries like Mexico, for example, which has built-in sugary beverage tax, but they also have a junk food tax now. And I think this starts to get into the question of political feasibility and what are people willing to do. I think in the case of sugary beverages, there is really good, clear data that this one particular product has some unique features and is sort of uniquely linked to negative health outcomes. And so I just think it's an easier case to make as opposed to broadening it to a lot of different foods. But I do think if you tax those foods, yeah, you'll see less consumption of them.
Thank you.
Sure, thank you. Hi, my name is Maria Watts-Newman, and I'm currently a college placement officer at the local high school. I'm also a New York City, Harlem bred on a corner bodega, as we used to call it in the hood. But to that point, what kind of studies are being done? Because there's a lot of talk about the sugary tax and the drinks and this and that. But you're all scientists and you're all in the healthcare field. What studies have been looking at really the choices that low-income, under-resourced individuals do at the corner bodega insofar as the quality of the food? So when you're considering that you're purchasing packaged foods with tons of preservatives, tons of additives, are they not perhaps contributing to the obesity epidemic as a result of there being some sort of physiological change within the human anatomy and biology that would contribute to the manifestation of an obese patient?
I mean, the short answer to that is we think the food swamp issue is hugely important, and are working with partners across the city to try to figure that one out. It's a tough nut to crack, but I think it's really important.
Okay, so are studies being done that will then, because my thinking is we're doing a lot of work to prove or disprove, and frankly, as I watch my French girlfriends down the baguette with the cheese, and, with the ham and Emmentaler, chased down by a flan coco and a double espresso with 3 lumps of sugar, I'm hard-pressed to think that our lifestyle, too, and our choices of how we purchase food and what goes into the manufacturing of those food items doesn't have something doesn't play into the fact that we are obviously a society of overweight people.
Yeah, I mean, we're not, I think we are all kind of on the same page that eating junk food probably is a big contributor here. So we're not currently studying that, but what we are looking for are what are the solutions to change that environment.
Okay, thank you.
I guess I'm the last. My name is Elizabeth Rappaport. I'm a retired pediatric endocrinologist with a long-standing interest in childhood obesity. And my question has to do with programs like Students Run Philly Style, Cadence Youth Cycling, the rowing program. They're wonderful programs, and they all produce, without argument, excellent results for those relatively small numbers of kids. I mean, I know you had 900 kids in the Broad Street Run, but that's still a small fraction of all the kids in Philadelphia, even all the high school kids in Philadelphia. Last time I looked at the data, there were almost 200,000 kids in the Philly school district schools. So what can we do to make opportunities for that 60 minutes of moderate to vigorous physical activity 5 to 7 times a week possible for all the children who are in school or even preschool? I guess I could half answer that question. Yeah. Can we make it mandatory to have physical activity in school? Can we teach teachers not to withhold recess because somebody's acting out in class? Can somebody address those issues?
So we have been having exactly that conversation with the district. The district actually let us do a district-wide assessment of physical activity in elementary and middle schools. And then we put that data together, made an infographic. I'd be happy to share that with you. And we presented to the chief education officer. He was completely on board because of it's not so much the improved academic outcomes, it's the improved behavioral outcomes that get the district on board. Kids in seats, that's what it takes. So we're presenting to the principals sometime in late June, I think. But I feel like there's something you have to say about this. It's even,
And when we're both involved also in a citywide task force that's being, lots of partners, all citywide partners, and on June 27th there'll be the release of the task force report around how we can increase access, because it's the same issue as it is with the food deserts. It's a poverty issue. And so there is a citywide effort to try to increase access to physical activity for all young people in Philadelphia.
and I believe the goal is a sports-based youth development program for every 4th to 8th grader.
That's right, yeah.
So on that optimistic note, please join me in thanking our panelists for